Hello everyone, I'm Leslie Cornwell, Certified Nurse Midwife with Midwifery Business Consultation. This has to do with the midwifery scope of practice. A legal disclaimer we put at the beginning of all of our presentations. This information is for general and educational use only, not intended to substitute for professional, clinical, or legal advice. We strive to keep our information as accurate as possible, but make no promises and guarantees. The course objectives, I want midwives to really understand the difference between state regulations, midwifery certifications, scope of practice, all these legal jargon things that do have a difference in what they mean. And so this section has specifically to do with the scope of practice. What is our independent scope? What needs to be co-managed, collaborated? What are the different kinds of collaboration that are out there? The difference between collaboration and supervisory relationships, and when it is time to practice outside of our scope of practice, we don't want to abandon patients. We want to do proper transfers prenatally, during birth, postpartum. What do those steps look like? So why is this important? I hear a lot of midwives, there's a lot of misunderstandings. They can preach off what is our guidelines and what is their view of midwifery, but when I ask the question of scope of practice, it's really interesting the answers I get all over the country. CNMs, CMs, CPMs all have slightly different scopes of practice based on their organization, but it is very easy if you Google search ACNM scope of practice for midwives, CMs, CNMs are going to clearly come up. Taking care of women independently, preconceptionally, primary care, gynecologically, pregnancy, birth, postpartum, and newborns the first month of life. It's very in partners for sexually transmitted infection treatment. MANA and CPMs, it's more of a vague guideline of supporting women during pregnancy and birth, not as much stressing gynecological services and primary care services. It's really important for midwives to understand how to chart, how to know this is independently what I can care for, this is something I can't care for, this needs to be collaborated, this needs to be a transfer of care, because it comes down to, you may have a position, a bias, maybe it's your sister, maybe you really love this person, they had a traumatic birth last time and you don't want to transfer, or the patient's refusing and now you have to practice outside your scope. How do you handle those situations and document? Because it comes down to legal ramification. If you are held for practicing medicine without a license or practicing midwifery outside of your scope without a license, you really have to know the legal standards and the guidelines and regulations that are out there to defend your policies, your protocols, your standards of practice, because that's what you're going to be held to. So it's really important to educate your staff, to educate the community, educate your clients. Right from the beginning, a new consult, you want to tell them what is the scope of practice of a midwife. We are low-risk healthy care providers. This is the definition of low risk. This is the definition of high risk. This is the situations we would have to, based on our scope of practice, collaborate with a physician to continue care, or based on setting or our scope of practice, need to transfer to another facility, transfer to another care provider based on their scope of practice. So let's go to the basics. What is scope of practice? It can mean a lot of different things to different people, but it's the definition of context. When you get your training, you get your skill set, you have competencies, what can you do with them? How can you practice? There are national certifications, there's national scope of practice recommendations, and then there's also state regulatory practice guidelines, and they may be typically more restrictive than what the national guidelines are. They may be in consistency with the autonomy level of certification, but some states have more restrictive scope of practice. So you can't just assume because as a CNM or a CPM or a CM, my certification says I can independently care for XYZ. If your state regulations say you have to be supervised to practice, to open a business, to serve clients, patients in your community, you have to look at your state regulatory scope of practice guidelines. So this is my favorite one, is independent practice. We are based on our national certification and international certification as midwives, independent care providers for low risk healthy women preconceptionally all the way to postmenopausal. there's a lot of misunderstandings or skill sets and training people get, but we can do primary care, we can do well woman care, we can take care of low risk healthy women in disease, chronic management, prevention of pregnancy, contraception counseling, abortion support. There's a lot of things we can do within our skill set, and so we have to make sure we have the skills, we're keeping up with the standards, we're following the local guidelines. It's the ability for us to be able to practice without an overseeing, governing provider, physician, organization to practice. Some states may have restrictions on that. Some states may say you have to be employed by a physician or a hospital to practice. Some states may say you have to be supervised by a physician, have something in writing. So you have to know, just because you're an independent care provider based on your scope and your national certification may not necessarily determine within the state you choose to practice that is the same guidelines you will be following. And even to more detailed, you may have a state that you're an independent care provider, but then you choose to be employed by a hospital. The hospital may have restrictive privileges. You can't take care of newborns at this hospital. You can't do X, Y, Z, even though it's part of your scope. So you have to really know every single layer. When you get a job somewhere, you get hospital privileges. You're deciding to practice in a certain state. You're going to open a business. You're going to choose to be a CNM versus a CPM versus a CM. You really have to know the scope of practice and guidelines for each of those scenarios. So what is co-management collaboration? It's a really muddied word. A lot of people get supervisory relationships and collaboration mixed up, and supervisory has a very different legal ramification. You have to be babysat. You have your charts checked. You have your services checked. You can't practice independently without that physician or overseeing organization's stamp of approval. Co-management collaboration is something that we do, whether it's formal with an actual agreement in writing or informal, to share decision making, to decide, you know what, she's not low risk healthy anymore. I'm going to chat with the obstetrician in town. I'm going to chat with the maternal fetal medicine. I'm going to chat with the pediatrician. We're going to have a phone call. I'm going to send them some lab results. They're working closely, medical director for the birth center. You have a conversation and you both make a decision together. What is the best plan based on this patient's individual needs and goals and situation? And then the midwives traditionally will still care for the patient, but it's maybe they rotate seeing the OB and the midwife throughout the pregnancy. Maybe it's just a phone chat once a month with the OB. How's her labs doing? What are the recommendations over the phone that the midwife should be continuing to implement? So it varies what is that co-management relationship, but it's definitely very different than supervisory. Co-management collaboration is a standard of practice. Family practice doctors collaborate. They refer to specialists all the time, dermatologists, oncologists, GI doctors. It's a professional collaboration to integrate better outcomes based on everybody's specialties. So it's a very common, respectful standard of practice to have collaborating relationships with people that are experts in the community outside of your scope of practice. So there's two kinds of co-management. There's the service line collaboration co-management arrangement, meaning you can have more formal contracts, especially hospital organizations, where they all say, well, you can refer to a dermatologist, but they have to be within our hospital's company's organization. So collaboration relationships can be more structured based on business benefits versus this is the best specialist in the area, this is who I trust, this is the philosophy of care I want to approach. And so it's more of a formal, structured system. Midwives can be part of it as employment. They could be part of it as getting privileges and supporting a local hospital and saying, look, I'm an independent care provider, but I'm going to exclusively use your services, your specialist, as kind of a cross-referral benefit. There's a lot of different ways that you can set up this. So for that service line, you can do it joint venture, a win-win for both people. You could do it as a business partnership. A physician helps with a medical director role and co-owns the birth center with the midwife. And then part of the collaborative arrangement is going to be supporting the patients together, or it could just be strictly the medical director administration role. And then you would work with another provider to do the collaboration for medical management. So you really have to make clear expectations of what is the purpose of everybody company? What are the operating agreements in the business? What are the outsourced policies, protocols for referrals, transfers of care? Is it the setting that's a challenge? Is it the scope of practice of the midwife? Is it the safety standards, the things that change? You really need to have clear expectations of this is when the collaborative arrangement is utilized, and this is how it's utilized. Are we going to make a phone call to the physician? Are we going to do a patient portal message to them because it's non-urgent? Are we going to transfer to the hospital and then the charge nurse is going to call the physician? Like, what does that collaborative arrangement look like? It's not just so much having one for certain scenarios and medical issues, but also what is that communication flow going to look like to respect both sides of the collaborative arrangement? So this is one that's really important. The other aspect of just thinking about collaboration is you can have it informal, you can have it formal. Collaboration is just the definition of supporting people based on the scope of practice expertise that the providers are bringing to the table. So when you have the situation, I wanted to bring it up for collaboration with initiating transfers, because if we get in situations that it's outside of our scope of practice, it's more time sensitive. This is where that higher infant maternal morbidity, mortality happens, that and this is that high unfortunate legal situation for midwifery scope of practice questioning. Did you wait too long? Was there negligence? Did you practice medicine without a license? Did you practice outside your scope? So these are those time sensitive situations where you're starting to initiate transfer and you made the decision based on your scope of practice, based on your assessment, based on the interventions you did and what's happening. What is that collaborative relationship? What is that scope of practice transfer look like to a local facility? So we're going to give the example of just in birth for this one. When you are a community-based birth center home birth practice, it's more time sensitive. You're not just a CNM in the hospital. You hit the call light, you have the nurse call the doctor, and then they're taking over care. You're chatting about it. You've got EMS, you've got the family driving, you've got time sensitive situations, many scenarios that we have to be very clear our scope of practice, our policies, our guidelines when it comes to intrapartum management. So there's different ways you can transfer care. You can directly call the 911 service line. You can call the local hospital you have a collaborating relationship with, talk to the charge nurse, talk to the OB/ER department, give them a heads up you're coming in. You can talk directly to the provider, depending if they're on call, how often they're being available for you. Depends on how big the facility is. You may be talking to the hospitalist. So that's part of getting proactive, your collaborative arrangements and your protocols for scenarios and how you're going to handle them. You really want to talk about the situation. What is the trauma? What is the situation? Is it minutes matter? You need to go to the local hospital. If minutes don't matter, you can talk about options and say, you know what, this one is really midwifery friendly. It's an hour away. You want an epidural, baby's good, you're good, we have time. So you have to make decisions on transfer, not just we're going to transfer, but what is the distance we can safely transfer? Can it be by car? Does it have to be by EMS? Most legal guidelines are going to tell you to call EMS no matter what, and then the family can refuse once EMS gets there to drive themselves. And then there's scenarios where the abandonment threat is present because the midwife will say, I think we should go to the hospital, and based on the family's beliefs, based on their past experience with the medical community, whatever the reasoning is, they say, well, I don't want to go to the hospital. I want more time. I don't want to go. You still should be calling EMS, and they can refuse EMS at the door because you get stuck in this really tough situation of being forced to practice outside of your scope of practice. And so midwives really, it's a sticky situation during transfer. So I want to have a clear conversation. How do you protect yourself? How do you give rights to your patients where, you know what, they refused EMS, you're documenting really well, you're still there, but they refuse, and they are very aware that this is outside your scope of practice. So what information, whether it's the birth assistant, whether it's the nurse, the midwife, when there is a transport happening, it's really important that we give a good, thorough assessment, because even though it's not a high topic with scope of practice, I think it's really important to have clear communication during those transfers, talking about the situation, what's going on, the backdrop, the history, the assessment you're currently getting and what you're recommending, why it's outside of your scope, why you need collaboration. Maybe you're just making a phone call call to the physician giving them a heads up. We've been pushing for 2 hours. We've been pushing for 3 hours. Baby's heart rate's good. Vitals are good. I more want to just give you a heads up what's going on, because that's that collaboration level versus, okay, we need to transfer. There's some bleeding issues. She wants some pain management that we don't have in the home setting. What are the situations that they're either risking out of your scope of practice directly, or the setting that's being chose for birth services no longer is the best place for them? So I just want to summarize, midwifery scope of practice is a really, really important concept for us to understand. There's national certifications, there's international guidelines for midwifery, there's state regulations, and there's local hospital private entity guidelines, credentialings for scope of practice. So there's many layers to this, and it's really, really important. Whether you're running a private practice, you choose to get employed by a facility, you need to understand your national scope of practice, the state guideline scope of practice, and what the local policies and procedures state about your scope of practice. If there's nothing written and you join a new practice and you are opening a birth center, a home birth practice, it gives you a vagueness of not having strong defense when you're in court, because then how are you going to say, well, this was my scope of practice for this facility, for this state, for this national US based certification? If you don't have scope of practice, you don't have hard guidelines to defend you of doing something. So there's some scope of practice gray zones that I talk to many midwives about. Ultrasound is an example of it. Ultrasounds for CMs and CNM, there's very clear guidelines of what we can do and what we can't do as point of care testing. We can't do 20-week anatomy scans and interpret them. Only a radiologist can do that. But we can do point of care issues. We can do gynecological infertility. We can do the baby's position, the fluid level. There's very specific things that ARDMS and ACNM have put position statements out about scope of practice. With MANA and with CPMs, there's not as much defense of what is the scope of practice with ultrasounds. And unfortunately, what's going to happen across the country is some legal case is going to come up to make a hard position, and it may or may not be in defending the midwives. So I always give people a good conversation. If they're adding ultrasound services to their practice and they're a certified professional midwife, I really stress this is a gray zone of your scope of practice. There's nothing saying you can do it, and there's nothing saying you can't do it. So we just have a good conversation of, if it comes down to legal defense, if it comes down to education, certifications, competencies, what do you have that you've taken to show and validate your skills and qualifications to offer that service part of your scope of practice? So these are really important conversations to have. And scope of practice is a really important thing to understand and clearly define within your own practicing guidelines, an organization you choose, the practice you start, the state you choose to practice in. And I reinforce, every time you move, every time you do a job, every time you're practicing in a new area, you have to review the scope of practice. What can you independently do? What do you need to collaborate, co-manage? What needs to be defined as a supervisory relationship in that state, in that local organization, hospital, facility? And what can you do autonomously, and what is just a risk out? It's going to vary greatly all over the country. I've done locum assignments the last 7 years, and I've done places where IHS facilities that the midwives are the most independent that I've seen across the country as far as management and care. The hospital puts additional independent and co-management standards than what the national certification does. We have far more autonomy for inductions, for VBACs, for preeclampsia, high risk scenarios than I see for most midwives across the country. And then there's some states that are super restrictive, the southern states, where heavily supervised, heavily restrictive of business ownership, heavily restrictive of independent practice. And so you need to think, when you're a new graduate, when you're thinking of taking a job, you need to know clearly what is the scope of practice in that local area. And it's really important to understand the difference between co-management, collaboration, supervisory relationship. So co-management, collaboration are very similar terms. They're used interchangeably. You're working together as a team. You don't have to be employed with each other. It's a supportive relationship with midwives, physicians, healthcare organizations. Supervisory relationship is completely different in the legal structure, the formal arrangements. It's a much higher vicarious liability risk to a physician, to a hospital entity. As soon as you get employed by a hospital, a physician, they're supervisory responsible for you because of that employee-employer relationship. If you choose to work in a state where there is scope of practice guidelines stating specifically that a supervisory relationship has to be in place, you can't independently practice your scope of practice there. You have to follow the more restrictive scope of practice guidelines that are in place.